This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of pre-hospital care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast, even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together, no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today I'm joined by Dr Maren Ranhoff Hov, who's previously been on the podcast to talk about pre-hospital stroke services and the ParaNASPP trial. Today we're going to be speaking about the evolving field of pre-hospital stroke medicine. So we're going to revisit the NASPP trial, but really what we want to do is just really dig into Maren's background, really, that spans both paramedicine and neurology. So Maren brings a rare and powerful perspective to the conversation from pre-hospital and in-hospital care. Maren's early days were working in the ambulance service in Northern Norway. She witnessed firsthand the critical challenges of recognising and indeed treating stroke in the field, a passion that would later translate into the foundation of her research career. So Maren has been on the podcast before on the 29th of July of last year with our co-host colleague Lisa Borrell. We'll put that in the show notes for this to frame this conversation. But really, Maren has been on the forefront of several groundbreaking projects, most notably the Norwegian ParaNASPP trial, which we're going to revisit in this podcast as well. And this really explored how paramedics use the NIH Stroke Scale that can improve pre-hospital stroke triage. She's also contributed to pioneering studies on mobile stroke units, pre-hospital CT, and indeed novel CT pathways. So her work has not only shaped stroke protocols in Norway, but also earned international recognition, including major quality awards from the Norwegian Medical Association. So in this episode, what we're really going to do is just do a deep dive into how Maren thinks about pre-hospital stroke spectrum, but also deep dive into TIAs, to large vessel occlusions, and indeed hemorrhagic strokes, to discuss how early decisions in the field can meaningfully change patient outcomes. Welcome to the podcast, Maren.
Thank you so much, and thank you for a very kind introduction.
No worries, it's lovely to have you back on actually. And before we do get an update on the ParaNASPP trial, if we could maybe just talk about pre-hospital stroke spectrum itself, what it means in practical terms for paramedics and indeed HEMS clinicians.
I think the involvement of treatment strategies and available strategies for actually improving patients' prognosis over the past years. It has been a revolution in stroke medicine over the past 20 years. And somehow pre-hospital management has been not left out, but kind of forgotten in this development. And we've been focusing a lot about how to structure our hospital care with streamlined and trained the in-hospital teams, and somehow forgotten about that symptoms actually start outside the hospital. And it's in the hands of the pre-hospital phase to actually be time efficient. Definitely there's part of this being patient delay, but if we look at the pre-hospital phase, some studies actually show that 50% of delays are in the pre-hospital service. And I think we need to focus more on this part. And so to structure pre-hospital care is important for patient prognosis. And we do have a lot of evidence these days that the pre-notification from pre-hospital services to hospitals are of really great. It actually has proved that it will change outcomes for patients, that patients are more the patients will receive treatment more efficiently. And we know that with stroke, to get treatment in the early phases of symptom development and disease development is crucial. So this opens up the Pandora's box of pre-hospital stroke, because we need patients to be presented for the hospitals for treatment. But stroke symptoms are so complex. So it's not only to have a paresis, it's about speech disturbances, it's about vertigo, it's about cognitive changes. There's so many aspects of stroke that are so complex to actually pinpoint in the pre-hospital phase. And when stroke has been a highly focused disease, especially in hospital, we haven't really been able to develop the tools with precision in pre-hospital care. So what will we do? Then we will open up this big box of symptoms and patients, and we haven't really been able to identify the right patients. And this gives us the great challenge for the future. We are so scared of missing a stroke because we know the consequences, we do have the treatment, but we don't really know how to find the right patients in the pre-hospital service. And that is what I'm so focused on in research and development. And I think that this is the really unsolved problem of pre-hospital stroke care these days. We have the tools, we have the knowledge, but it hasn't been developed to the pre-hospital part of the service.
Yeah, indeed. No, indeed. And to your point, actually, there's lots of subtle signs and maybe more classic signs, but there's very much lots of non-classic signs. And actually, that is a problem because, as you were saying, there is rarely a classical presentation of any of the pathology, which is a real challenge, actually. I'm going to roll two questions into one, really, and this is around signs in the field that can help us differentiate between maybe types of stroke or not really. I'm really kind of notioning towards, pre-hospital stroke screening tools like FAST or Rosier or CPSS. Just are they still in your mind sensitive and specific enough to kind of differentiate between types of stroke or indeed not?
I think that the pre-hospital scales that you mentioned, they have quite good evidence that they are good in the way of identifying large vessel occlusion strokes. And when we talk about large vessel occlusion strokes, I need to just elaborate a little bit on what that is. And if you have the big vessels of the brain that are the major source of blood supply for the rest of the brain anatomy, the large vessels will be the ones that are connected to the central vessels going up from the heart through the neck arteries. And these vessels will be the supplier for the quite extensive blood supply network. And if you have a clot or a bleeding in one of these large vessels, then it will affect the other smaller networks of vessels, and the core of the damaged cells will be more severe, and the potential of a severe and quite big area of damaged brain tissue will be at risk. So the large vessel occlusions will be central arteries clogged or with a bleed, and the symptoms will be quite severe. And we very often see these large vessel occlusions in the arteries that supply motor functions and sensoric functions, what we will call the middle artery. And for these patients, symptoms will then obviously be motoric. And the motoric symptoms are the paresis or the paralysis. And there will be half-sides symptoms. And so this will be the classical stroke symptoms. And what we should be aware of is that these scales that you talk about, they are scales that would address classical motoric symptoms. They're good in identifying these symptoms. But you must be aware that they are not identifying other symptoms like cognitive, vertigo, visual disturbance, speech disturbances, and so on. So you will miss then, if you're focusing on these pre-hospital stroke scales that are evidence, really good high sensitivity and specificity in identifying large vessel occlusions, you might miss other strokes. So you can't be sure that it's not a stroke, but you might identify a large vessel occlusion stroke or a severe stroke. And that's the challenge, because most patients do not have a large vessel occlusion. Most patients do have a less severe stroke or a stroke in other regions of the brain. And that makes it complicated.
Yeah, and no, indeed, absolutely, and to your point, we really want to capture and filter and indeed articulate all types of strokes. So we need a tool which is, as you were saying, far more sensitive than just the large vessel occlusion. What we'll do in the show notes is we'll put links to the FAST test, to the Rosier test, and the CPSS test, just for understanding, and we'll put those in the show notes. But actually, if I could pivot, Maren, and really just get you to speak to really an update actually on the ParaNASPP trial, which again we'll put in the show notes for people to go back to together with the other podcast. But yeah, if you could give us an update, that would be fantastic.
The trial is finished, and we have published the main results. And what we did find is that with introducing NIHSS, which is the more complex scale with 11 different items to go through, it will cover more symptoms than the large vessel occlusion scales. But however, NIHSS is not a perfect scale either. I just need to be clear about that, but it covers more symptoms. And what we did find in the ParaNASPP trial, introducing NIHSS in the pre-hospital field, is that you could identify more of the patients with the subtle symptoms, with the non-large vessel occlusion symptoms. And we're now looking into data to find if there's any sex differences in this material, because other studies from Australia, for example, and some international review studies have shown that there might be sex differences in symptom presentation of stroke, and that women might be in a greater extent under triaged having a stroke. So we're looking into that in our database, if we can find any patterns in our data that there are sex differences. And we're also looking into vertigo specifically, because we know that vertigo is a real challenge pre-hospitally. Most vertigo patients do not have a stroke, but the ones that do have a stroke are so crucial to identify. And we're looking for patterns if there are some symptoms that are more often presented in this group. And the aim for these focus is to maybe in the future add or make a new kind of decision tool with more detailed guidance for clinical assessment. Maybe there will be different questions asked if there's a male of 80 with the sensoric symptoms compared to a female of 42 with more cognitive symptoms, just to make an example. But we need to have robust evidence before we implement these kind of guidance or tools in the field. And now we're doing this, what you can say, a more boring kind of analysis of the data material that we already collected. And hopefully this will lead up to a new tool that we can test in clinical studies in the future.
So what we're seeing in practice, Maren, is really the evolution, almost like the cath labs, like PCI labs. We're starting to see the evolution of 24/7, slowly but surely, 24/7 thrombectomy theatres and indeed services, where you can start to take patients direct to thrombectomy, almost as a pathway, as a pre-hospital pathway. Could I get you to really, in a way, speak to that? We're starting to see the emergence within London, and even indeed outside of London, within the UK and indeed in Europe, whereby these services are starting to be articulated and indeed extended to become 24/7. Could I just get you to, in a way, to speak to that and how that service is evolving?
I think we have a challenge compared to how cath labs and pre-hospital triage was established, because we don't really know in the pre-hospital field if there's a bleed or a clot. And there's some real important work done by a Catalonian group of stroke researchers, and it's called the RAISE-CAT study. And what they did was actually what you're asking. They wanted to triage patients with symptoms that were severe, so symptoms that would be likely a large vessel occlusions. So these hemiplegic patients, or the patients that would have a FAST or a Rosier or a Cincinnati pre-hospital stroke scale symptoms, and we'll triage them directly to the thrombectomy center. And this is a good idea because you want to really save time for these patients. And if they are to end up in a intervention center in the first place, then they should go directly to these centers. But they found that actually the patients that had a bleed, and symptoms will be similar if you have a large bleed or a large vessel occlusion. So the intracerebral hemorrhage patients, they had a worse outcome in this study when they were directly triaged to an intervention center. So by implementing these kind of triage systems without knowing if it's a bleed or a clot, you're actually doing harm to the hemorrhage patients. So this is controversial, and we need more evidence. And what it really what it really underscores is that we need pre-hospital advanced diagnostics that can tell us if there's a bleed or a clot. And I think that's the new, really most important pathway for advanced diagnostics. We can't wait for these diagnostic tools in the hospitals. We need to implement them in the service.
Yeah,
and then
indeed.
we need to find tools that can be implemented.
Yeah, indeed. Well, we'll get there within the conversation actually, because that's part of my a few questions a bit later on about CT scanners and
Yeah.
how we can really embed those. I guess before we get there, Maren, could I get you to really maybe unpack, because quite rightly your research has really focused on early recognition and early transport to facilitate long-term outcome, especially for large vessel occlusion and or hemorrhagic strokes. But could I get you to really, because to your earlier point, and I think you said this in the last podcast, it really, the articulation, the care doesn't start at the door of the hospital, because the pathology doesn't start at the door of the hospital. It starts in the pre-hospital phase, but also it's about the spectrum. So it's a good rehabilitation as much as it is good articulation at the start, and it's the patient pathway to good outcome. So it's every part. It's the pre-hospital phase, it's the in-hospital phase, it's the rehabilitation phase. But could I get you to speak to really just to the impact of early recognition and early transport on patient outcome?
It's everything about early recognition, because time is brain, and that's not just something said in a populistic way. It's really true, and we have so much evidence on this. And we know that if you have early treatment, and when we talk about early treatment, it's in the golden hour, just as we talk about trauma patients. So the golden hour is as a real for stroke patients as for other emergency conditions. And if you get treatment within the first 60 minutes, the outcomes are significantly better than in the later hours of the treatment window. But I also need to address that the treatment window for thrombolysis is still 4.5 hours if you're not in a center that can do extensive imaging with perfusion imaging. And not all patients after 4.5 hours can receive thrombolysis, but some can. So there's still really important to get these patients as early as possible. And the risk of getting complications with intracerebral bleeds, and that's what we are worried about, will increase dramatically with time. So it's more efficient and it's less risk to get treatment early. And then, since patients do have their strokes at home, at their workplace, in their leisure time, it's in the pre-hospital service to actually reduce delays. And then every part of the chain, from recognition at the dispatch center and early assessment by paramedics and the pre-notification to the hospital and to be transported to the right level of care is of high importance. And it actually can be measured with better outcome and quality of life. And I think this location-based medicine that we have with transporting patients to hospitals needs to change for stroke, because pathophysiology do not wait for our localization of hospitals and CT scanners. We need to treat patients where they are.
So just before we go there, actually, if I could get you to speak to, if possible, from your anecdotal experience, Maren, just indeed, and where you have experienced pre-hospital interventions really changing the trajectory of patient stroke outcome. Before we get to the kind of pre-hospital CT scanner piece.
I did once publish a case about something different that I think is quite illustrative, and that's for subarachnoid hemorrhage. We don't talk about that much. We talk about thrombolysis, which is important, but there are so many other patient groups that would be of benefit for early recognition and diagnostic approaches. So once I did publish this case with the patient in Norway, he was only 30 minutes from his local hospital, but it was 2 hours drive to go to the neurosurgical intervention center. And this patient was so lucky because we had our mobile stroke unit just nearby. And we actually calculated that being able to take a pre-hospital CT scan on the road with this patient just a few minutes after he had his thunderclap headache and his symptom onset, we saved 4 hours just in intra-facility transportation. And for subarachnoid hemorrhage, this is actually about life and death. So that's just one story, and actually published that one because it's remarkable that it's not, distances are not very long. It's 30 minutes to a CT scanner at a local hospital, but that was not the right level of care. And that's what it's all about. It doesn't help to get a diagnosis if you can't do the treatment. So this triaging patients are of importance. And we also have so many patients that we have been able to diagnose and start thrombolysis in the pre-hospital field and recognize that this might be a large vessel occlusion. And instead of then driving to a local hospital with a large vessel occlusion, being able to pre-hospitally triage them direct to the angio suite, and that really makes a difference. I think also for patients that we haven't been able to go out with the mobile stroke unit, just with pre-hospital personnel being competent in stroke symptoms, being able to recognize them early, and actually just bypassing the local GP, just delaying patients in the ER, being able to directly notifying. There's so many of these real life stories and patients that had a hemiparesis and after thrombolysis being given within 60 minutes, they can just walk out of the hospital and go back to their lives weeks after. And this is what encouraged me to continue this work.
Yeah, indeed, and it's so powerful in a way because we actually interviewed a clinician that was part of a thrombectomy service within the UK, and he said, to your point, Maren, he said, just as you can see the ST segment reducing from PPCI, you can actually see from thrombectomy and, like you said, a chain of intervention, the hemiparesis, or indeed the regaining of physical motor function back to the limb in real time. And he said it's amazing to see, physiology sort of regaining its ability in real time. So let's go there, Maren. Let's talk about pre-hospital CT scanners, because to your point, early recognition and accurate recognition is almost the cornerstone, really, of early intervention and getting them to the right place. There is a number of projects ongoing globally, but certainly in Norway, there is a pre-hospital CT scanner project, certainly within the air ambulance and or otherwise. Could I get you to maybe just unpack the where the project is, and indeed maybe some key foundations or gateways that the project's sort of entering through at the moment?
Absolutely. Thank you for asking. I think that we need advanced diagnostic tools to be able to start treatment. And I think we need to think beyond the technology that is known to us. So CT scanner obviously is of great interest because we know that CT technology has, if in the right time frame, up to 100% sensitivity of identifying blood. So it's an excellent tool. However, CT scanners are traditionally heavy, and we need to address the radiation exposure risk with CT scanners. That makes it more complicated. There are some CT scanners that you can get from different suppliers today that you can put in ambulances, and mobile stroke units is a concept that globally is implemented in quite a few systems. Especially in Asia and in the States. In Europe, we are a bit behind in development or in implementation of mobile stroke units. And these scanners, they weigh around 500 to 800 kilos. So obviously we cannot take these scanners in air ambulances, and it's also challenging actually as a country of like Norway with narrow roads and a lot of weather and hilly areas and rural areas, remote areas, to have scanners in ambulances that weighs up to 800 kilos. So the ideal would be a scanner that is lightweight, that could be implemented in maybe one ambulance in each ambulance station has these kind of scanners, and then you can dispatch this special unit if needed. Not like today when you have only these highly specialized units that are more for research purpose than actually implementation. But then we need a change in technology. And the good news is that these technologies are evolving. So there are some technology developing at the moment that looks promising. And we might have some prototypes for lightweight CTs in the next years to come. And definitely we are looking into that, and we are collaborating with Australian Stroke Alliance to test this technology. And hopefully we will have some pre-hospital testing in a few years to come. And this will open a whole new world, not only for stroke patients, but lightweight CT will be a game changer for trauma patients, for neurotrauma, but also for all other trauma patients. Which clinician wouldn't like to have a CT scan in the field? I mean, it's a game changer. But I also want to address other types of technologies, because CT scanners are there has a huge potential, but there's also some challenges. But what about a biomarker? If you have a biomarker with just a point of care test that could give you 96% sensitivity of blood, you might not be able to give thrombolysis, but in other cases where you are not sure if it's a stroke or not, it can really make the difference in your decision where to take this patient. In trauma patients, just to avoid taking a CT scan or taking a patient's hours to a local hospital to get a CT scan. These biomarkers, I think, are very promising. And we can also look into other kind of treatment of stroke for the hemorrhagic patients who would be benefit to get blood pressure reduction. A biomarker might be sensitive enough to start that kind of treatment. And that would be really good for that patient group that up to now has been not neglected, but we've been so focused on identifying the thrombolytic patients and the large vessel occlusion patients. So the hemorrhagic patients has somehow a bit forgotten. And I'm also quite interested in electromagnetic scanners in the microwave field. Small scanners that are very promising, high sensitivity of identifying blood. And which pre-hospital clinician wouldn't want a helmet in a bag like a stroke buster that could go out and scan both stroke patients, unconscious patients without known cause, trauma patients, and so on, and be quite with a quite high sensitivity and specificity. Maybe the future of being able to giving thrombolysis is still to be a bit more elaborated and developed. But for triage, I think these tools are so promising. So in my futuristic view, I'm hoping that we can have biomarkers compared with clinical assessment and a scanner, and we can really implement this in a broader scale, not into these highly specific units made for research, and that all ambulance stations and even helicopters and fixed wing ambulance can have this equipment available.
Yeah, which would be amazing. And like you said, an absolute game changer, actually.
Yeah.
So let's talk about telemedicine, because there are two distinct facets, actually, in telemedicine in its number of guises and forms. It could be really around, giving, receiving thrombectomy, or indeed neurosurgical center, the physiological data, pushing it from the pre-hospital environment to the hospital ahead of time. So really giving all that augmented information back to the service, so it's not just on the handover, they've got it ahead of time. So let's talk about telemedicine, but I just want to sort of sneak in the AI question as well, because I am aware that AI is changing the way that the scans are read, and the sensitivity of reading scans. Could I get you to speak to both?
Yeah, definitely. Shall we start with scans, since that's where
Sure,
we ended?
sure.
And I think AR for scans are really, really important that we look into. My biggest concern is that we are not being and detailed enough, or that we are rushing development, because these AI models are not better than what we train them to be, and we need to be aware of that. So, and I'm also a bit worried about actually what our subject is today, and that's pre-hospital identification of patients. And if you have an in-hospital view of this, you do miss the big picture, because our population in the pre-hospital field is heterogeneous. And it's so many stroke mimics. There's so many differential diagnoses that we will identify as possible strokes. And if you are to develop an AI tool for pre-hospital identification, you need to train them on this heterogeneous population. And that's time consuming and it's resource demanding. But we need to do that work before we can get any tools that are really safe to implement. So that's something I'm a bit worried about, and I'm really addressing in all times of forums that I'm invited to. It's promising, but we need to do the really hard work to get this tool robust and reliable. And that's also for image interpretation with AI. I think that we need a lot of scans from this heterogeneous population, and we need to collaborate internationally, and to get just as many scans as possible to make the tools robust. But absolutely, the potential is remarkable. We just need to do the hard work. And so to telemedicine. Telemedicine is also a game changer. Because if we look historically, some of these specialized units with mobile stroke units, with CT scanners, they all were staffed with in-hospital personnel, because we were not sure what could we train pre-hospital personnel to do. There will still be need of stroke-trained physicians in at least some of the decisions that will be needed. Not all strokes are straightforward clinical decisions. But should we staff all these pre-hospital units with in-hospital personnel? From my point of view, absolutely not. And then telemedicine really is a game changer, because then you can have pre-hospital personnel that are specialized because they are able to communicate digitally with video transferring imaging with in-hospital personnel. And then pre-hospital personnel can be actually cherry picking who they want to put into the decision procedure of patients and triage. If they want to talk to a neurosurgeon, then they can do that. If they want a neurologist, they can do that. If they want internal medicine and so on. And they're not relied on the one in-hospital person that is staffing the vehicle. So this is really interesting. And I also think that telemedicine is of interest at dispatch. And it's a tool that we need to explore in a greater extent. There are some interesting research from Norway on video at dispatch in mild, moderate trauma patients, and it has really interesting findings. And I think this can also be of interest in neurological assessment. But I got the same kind of concern with the especially AI in this video dispatch, video paramedics with hospital. We need to be sure that the data that the AI is trained on is the real data that will be in the real life assessments. But if for telemedicine to be utilized in a greater extent from dispatch to paramedics to hospital, I definitely think that there's a great opportunity for better triage in the future.
Yeah, absolutely, absolutely, and actually to your point around just the protection of information, so that actually, and even just something as simple as a voice to note, so that actually the handover that maybe a paramedic gives or a pre-hospital team give can be listened to by both the a neurosurgical interventionalist or indeed surgeon, but also could be listened to by the rehab staff, so that actually there's articulation and preservation of that initial handover, which doesn't die there and then in the moment and actually lives on, so that there can be almost this auditory chain that can be really, so you can really start to hear the initial handover from two clinicians removed, which gives you almost that far much more transparent patient chain and patient transfer.
Yeah, I couldn't agree more. And this is what I'm actually training my physicians in Oslo University Hospital. We do have like neuro team training every week, and I'm stressing this: when the pre-hospital personnel, when they leave, all their information is gone. You need to be focused on the handover, because this valuable information will be lost if you don't get the full extent of that information source. And then telemedicine can really be helpful. Absolutely. And I also think for dispatch, this is really, really interesting, because when we think about dispatch, it's the resources that are effectuated by dispatch. It's defining the rest of the pre-hospital service, actually. So thinking about that, at least in Norway, they are using tool of index criteria that developed in the 90s, and these are still the tool used for today's highly advanced and highly competent pre-hospital service. And it needs to be, we need more research on dispatch, and we need more development on dispatch, because I think in all systems that I've been involved in internationally, the challenge of over triaging patients and over using pre-hospital services just because we don't have the tools that are specific enough is a growing real burden of this system. And it's almost collapsing, actually, because we don't have tools that are fitted to the task. And that worries me a lot.
So just before we finish off, actually, Maren, a couple more questions really. One would be around interdisciplinary collaboration. I think one of the big aspects, and this is more generic just than stroke, is just the MDT approach, the multidisciplinary team approach, and really, to your point just about telemedicine, bringing in hospital colleagues along on that journey with you and sharing information more synchronously, longevity of information, preservation of information, but also getting potentially your perspective in the pre-hospital environment. So I can speak with you, I can consult with you, I can have some real-time dialogue. But could I get you to speak to really maybe some of the cornerstones of effective communication and collaboration that you see in the future? Image sharing, standardization of handover protocols, any of these things?
One of my experiences being an on-call neurologist is that there's a black box of information, and I don't get any dynamic updates. So you get at least at my hospital, you have a pre-notification, and it's the vital scores and the clinical details from that moment. But then transportation time might be 30 minutes, and I don't get any information in that 30 minutes. So in my futuristic view, I hope that this will be dynamic and that telemedicine, AI will help us to get more dynamic information transfer. So I would love to have a big screen in my hospital for my patients, and that I'm just not, I don't want to be in the ambulance constantly because that would be disturbing, but I would like to have the updates that just comes directly in telemedicine, teleradiology, and if we have imaging, then everything will be updated in real life digitally, so that when you arrive with the pre-hospital team and I'm ready with my in-hospital team, there hasn't been a 30 minutes or a 40 minutes knowledge gap between us with what happened to the patient. Then we are at the same page, real life updated on what happened, what intervention has been done. And then I think also communication will, that would help a lot on the communication. And what we found in our ParaNASPP study that actually looked into the challenges with communication between in-hospital and pre-hospital teams was that when you don't communicate in a structured, objective way, then you have less confidence in the other team's knowledge and competence. And this really makes communication really challenging. But if you are more on the same page and you are communicating in a structured, objective way, then trust also develops. And I think trust in information is the key factor for this, and that telemedicine will be a really helpful tool because we are able then to dynamically update each other on patient progression and patient how patients are evolving in the pre-hospital field. So, but I also want to have one short thought that takes up a lot of my time these days about telemedicine, and that is it's how you are presenting the patient when you decide to start the telemedical communication. So what I've been thinking a lot about is when you are a physician and you are relying on telemedicine, you need to be aware that there's only a short time frame that you are exposed to. And actually it will be more demanding for pre-hospital personnel to get access to telemedicine. I try to explain this because then you do have a specialist that might give you a broader tools and more possible to start treatment, more complex decisions and so on, because you have the telemedicine security kind of competence in there. But what you would need to be aware of is that you decide when to start the telemedicine link, and you decide what narrative the physician is presented. And that's a lot of responsibility. The physician is only exposed to a very short time frame and just partly all information, and that really you really are then you have a lot of responsibility in how you present this narrative telemedical with the physician in charge of decisions. So
Yeah, listen,
that's a
I
worry I
agree.
have.
Yeah, I agree with that. And I think actually there's a couple of things to that. One is getting a conciseness to a conversation quite quickly. So, Maren, I'd like to talk to you about a 45-year-old female, left hemiparesis and XYZ, but just in a standardized. So I'll give you and my major concern straight away, right out of the gate, giving you signs, symptoms, and maybe my top 2 or 3 worries. Might be window of intervention or a window of onset. Sorry, but I front load a conversation straight away. You have my top fears as a clinician, and that might be stood away from the patient, but essentially you know what is prescient on my mind, so you're not guessing. And number 2 would be, to your point, around trying to confer to you the longevity of this symptomatology and maybe the physiology and pathology which is evolving, and give you a sense of baseline, how this has deviated from baseline, if it's just grossly deviated or not, but give you a real feel for the, like you said, the presentation and the acuteness of the presentation,
Yeah,
and to do that in a short time frame where you have my major concerns straight away, and then you have the acuity of the presentation as quickly as possible,
yeah,
to really, and then maybe you have some physiology and data pushed to you as well, that you can see. So it's not just a phone call, maybe it's an iPad or something else, that you then can start to be innovated with, essentially with a triage of a priority list of my concerns, the patient presentation,
yeah,
and the deviation from baseline
yeah,
of physiological data. But that innovation gives you a feel for the situation far much more than a linear phone call where it might take you 10 minutes or 5 minutes to get even just to my
yeah,
concerns, which
yeah,
isn't, you're constantly like, okay, Owen, why you come, give me why you're calling, give me and then give me the presentation, give me a real feel for what's happening right now, why they've called
yeah,
an ambulance. So I agree with you with that. And there's another thing you said earlier, which I absolutely fundamentally agree with, and I'd love to get your finishing comments on this, is we all crouch around in an ambulance or a helicopter and in a resus room around these small physiological monitors, around these screens. Actually, there's a real case, and indeed argument, to have a 32-inch or 40-inch TV screen above every resus bay, slaved from the monitors. So everyone around that resus bay, everyone in that helicopter, and indeed everyone in that ambulance can see the images, and they might be ultrasound, CT images. They might just be the data from the physiological monitor. But actually, we're not all crouching around these small, and it happens within the resus bay a lot, there's no centralization and indeed democratization of this information across right above the patient's head. And it's not necessarily the patient can see that, but it might be above their head on a 40-inch TV screen, and that's the handover information. So there's longevity of information there. There's the scans which can be slaved to that monitor, and we there's a real piece around having this centralization, a single point of truth within a logistical platform like a helicopter or an ambulance, but fundamentally within a resus bay, where there's actually intermittent attendance of various interdisciplinary colleagues, and some of them may not have heard the handover, some may have. There's segmentation, there's confusion a lot of times. So a single point of truth, there's no ambiguity, there's clarity, there's longevity of clarity, and that's a real piece of technological advancement just to get that single point of truth to the teams.
I couldn't agree more. I think what worries me with too much focus on this new technology and to give them too much space. And I must address this as, I think, maybe as a neurologist as well, because what I've seen is that what I've been questioning for myself, I've always been 100% sure that we need more competence focus in the pre-hospital personnel. Tools are important, technology are important, but I still believe that the competence is the most valuable. And then with all these new tools, with the longevity of details, that the complexity of details with scans and everything that we are now at least we are almost implementing all of this. We're still not there, but we believe that this is the future. I must address the importance of competence, because we might be we might be fooled by these tools that they can that we don't need the same kind of level of competence, that the physician is in the hospital and it can be telemedical appearance in the ambulance or the helicopter, and the physician can then make the decisions and so on. But opening up all these tools, I think that the on-site patient care competence is of more importance than ever, because all these tools opens for more detailed decisions, more absolute decisions, more responsibility for the decision makers, and then the competence in the personnel that are next to the patient needs to be even higher. That's my absolute statement. And we must not be fooled by all this technology that we can replace competence in pre-hospital personnel with these tools. We need to increase it even more than before, because these tools opens up a whole new world with the possible decisions and treatment opportunities, but also more responsibility for the on-site paramedic or pre-hospital physician. So that's my statement, and that's my closure, I think.
Indeed. No, listen, that's powerful and absolutely true. And just as we look to come into land on the podcast and indeed on the episode, could I get you to speak to, so you speak to, I think competence is absolutely a fundamental prerequisite. Could I get you to really speak to the next 5 or 10 years around pre-hospital stroke care? We've spoken about the adage of imaging and the compactness of future technology like CT scanners, but could I get you to speak to, you've really just notioned there towards, competence and education needs to really match that level as well. I guess it's multifaceted in a way, but could I get you to really speak to what you see the next 5 or 10 years looking like?
Yeah, I think the next 5 years will be in the name of research, because we are still quite undeveloped research-wise in pre-hospital stroke care. And we need to look more into the pre-hospital system, not specialized unit. That's my statement. I believe that the mobile stroke unit development and all the research that has been done is of very high importance, but to utilize the resources and to actually make this available for the broad population, then we need these tools and diagnostic possibilities implemented in the pre-hospital service, not in specialized units. And so that's why I hope that we're shifting our focus research-wise to be more focused on the established service. And I think we need at least 5 years to research and develop before we can look into the implementation. But if we are now focusing on new tools and we are really putting in a lot of work to do validation studies and to do this pre-hospitally, not only in hospital, then I think then that 5 years after, so for the 10 years, then we are looking into game-changing implementation of pre-hospital, not only diagnosis, but also treatment. And I think that thrombolysis will be a pre-hospital task for future treatment. Blood pressure lowering in the hemorrhage patients will be a pre-hospital task. But for this to be a realistic scenario, we need the development of the tools that can differentiate the subtypes of stroke. So 5 years of research, and we need to shift our focus. We need to focus on the pre-hospital service, not specialized units only. And then the next 5 years will be implementation and game-changing of pre-hospital treatments. Yeah.
Fantastic. Maren, listen, thank you. It's always a pleasure to catch up with you, and thank you so much.
Thank you so much for re-inviting me, and I'm so happy to be able to share some thoughts on this field. So thank you so much.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.